Well, good afternoon, everybody. My name is Pamela Exaverius, and I welcome you to our first virtual research spotlight, sponsored by our Maternal Child Health Center of Excellence at St. Louis University. We are excited to offer this today, and I would like to begin by thanking our Center of Excellence team and planning, coordinating, and being all around best colleagues ever on this task, including Dr. Maya Tibet, Kaylee Cunningham, Maya Terry, Dr. Shen, and Dr. McMillan. Today, we have planned a panel on the topic of COVID-19 and preterm birth. We seek to address today the seemingly contradictory findings that have been in both the news and in the literature regarding the impact of COVID-19, being related with both increasing and decreasing rates of preterm birth. Maya, if you wouldn't mind going to the first slide. So here you can see, this is some of the early data, some of the early notices that came out around preterm birth, where it shows that in Ireland and in Denmark and in the Netherlands, that there was decreasing rates of preterm birth rate in those countries. Following that has come some evidence coming out with this, for example, JAMA article showing that they looked at a diverse cohort and found no increase in preterm or stillbirth rates. Next slide, please, Maya. And still again, in England and Wales, they found no relationship between preterm birth and COVID-19. And we have been hearing some things around preterm birth rates dropping during lockdowns, but that it's not for women who have COVID-19. When women actually are infected with the virus, they have an increased risk for preterm birth. So that really leads us to our panelists today. Our panelists today are going to talk about some work that they recently published. They seek to address these issues. First up is Dr. Vincenzo Berghella. He's with the Division of Maternal Fetal Medicine in the Department of Obstetrics and Gynecology at the Sidney Kimmel Medical College at Thomas Jefferson University. He will present findings from a recently published research letter in the American Journal of Obstetrics and Gynecology titled Decreased Incidence of Preterm Birth During Coronavirus Disease. To follow, we will have Dr. Kate Woodworth, who's with the Center for Disease Control and Prevention and works with the COVID-19 response team. And she will present findings from her recently published paper in Morbidity Mortality Weekly Report titled Birth and Infant Outcomes Following Laboratory Confirmed SARS-CoV-2 Infection in Pregnancy. Together, they will make two brief presentations describing their recent work on this emerging knowledge on the impact of COVID-19 on preterm birth. After their presentations, the panel will take questions from our audience today to the best of our ability. Our hope is at the end of this panel, we will have a better understanding about this emerging knowledge regarding the impact of COVID-19 on preterm birth, which is critical for us to understand as we continue to think about identifying solutions for harm reduction. A few housekeeping items. First, we will be able to offer one CEU for those who are interested in using this presentation towards CPH recertification. If this is something you want, please type your name in the chat box so that we can follow up with you later. We will also be recording this presentation and making it available on our Center of Excellence website. We also ask that you hold your questions until the end of the presentation, at which point, please either pose your questions in the chat box or raise your hand and we'll call upon you. Unfortunately, due to a family emergency, Dr. Berghella is unable to be with us today, although he has provided a recording of his presentation, which will be first up. If you have questions specific to Dr. Berghella's presentation, we will collect those today via the chat and send them to him for response. Finally, we will send a copy of today's presentations to all registrants following today's panel. And with that, let's begin with our presentation by Dr. Bergella. That's us deep diving into that presentation.
Hi, my name is Vincenzo Bergella. I'm Director of Maternal-Fetal Medicine and Professor of OB/GYN here at Thomas Jefferson University in Philadelphia. It's a pleasure for me to give a quick lecture to you on COVID-19 and preterm birth. Obviously, the goal here is to eventually have healthy moms and healthy babies, despite this difficult pandemic we are going through. Many of our pregnant women have actually gotten vaccinated, and I strongly suggest pregnant women get vaccinated, as I have written in scientific articles, that have been on TV and Facebook and Instagram, everywhere I can be on. The vaccines for Pfizer and Moderna are both safe. I have no conflicts regarding this, except again, a passion for healthy moms and healthy babies and a passion for preterm birth, which continues to kill one baby every 30 seconds, with over 1 million babies dying from preterm birth every year. We can do better. When COVID-19 hit, this article is from April last year, we went on the attack against coronavirus. I'm editor-in-chief of this new journal, AJOG-MFM, which is doing really well. And we published many articles on COVID-19 and pregnancy, since everything was there to learn. And we know a lot, including maternal-fetal medicine, complication, guidance, management. I want to thank Dr. Rupce Bolig and many other colleagues who have accompanied to this evidence-based journey to decrease complication from COVID-19 in pregnancy. COVID-19 has happened to hundreds of thousands of pregnant women around the world. Most of them do well, have a symptomatic or mild disease, like most non-pregnant adults. But 1% have critical disease, and those are really the ones who have more preterm births. But I want to emphasize, these are only 1%, as we, with the New York group of Breslin, our group at Jefferson, with Dr. Chris Williams, have published extensively on. In fact, we know the common timing of the disease, even in pregnant women, even in severe and critical. Usually it takes about 7 to 8 days to get to the worst phase, when oxygen may be needed and admission may be needed, sometimes even mechanical ventilation. So again, 1% of women, as you can see here, can get critical disease, end up in the ICU, and get very sick. Those are the ones who have more preterm birth. They, again, get admitted to the ICU, they need oxygen, can have multiple organ failure, and while there are not many, they can do bad. And we do know that pregnancy puts them at risk, just like for flu or other viruses. When a pregnant woman of the same age and same risk factors gets a virus, including COVID-19, there are higher risk of being in the hospital, being admitted to the ICU, getting ventilated, and even of dying. So clearly, for the 1% of women who get COVID-19 and get critical disease, then preterm birth is more common. And again, we've reported that and up to date in the special coronavirus chapter and in many other articles. But those are the minority of women. You know, there are 4 million pregnant women in the US. Obviously, the very minority, thank God, 10% or less have gotten COVID-19, and only 1% of the 10% or less get critical disease. So we're talking about small numbers overall, while the rest have been pregnant during the pandemic and has seen their care change dramatically. We do a lot more telehealth visits, as you can see from the schematic we published again from Care at Jefferson, and they come to the office less often, they stay home more often, and obviously their work has changed, their home life has changed, their travel has changed, a lot of stuff has changed. So some have started to look at how women in general do during the pandemic. There are reports of stress, depression, different things. And we looked at preterm births, and this is the data that I was asked to present, and it's been published in, again, AJOG-MFM. If you go to www.ajogmfm.org, you can find this and many other articles on COVID-19 and pregnancy. And we did report that when we looked at March to end of July last year, we actually found that preterm birth during the pandemic, this first column here, was decreased compared to the same year, to the same period, but previous year, 2019, March to July. So again, pandemic time, first column, you can see here that in terms of patient population was somewhat similar, but preterm birth were decreased, was less than 10% overall during the pandemic, and 12.6% the year prior. So a 25%, we found a 25% decrease in preterm birth just because this pregnancy happened during the pandemic, which is quite remarkable. We don't have too many things that decrease preterm birth by 25%. As you can see, preterm birth less than 34 weeks was also decreased, and this by a whopping 49%. So early preterm births were particularly decreased. You can see here, preterm births less than 28 weeks were decreased by more than a half, significant finding. And when we did subgroup analysis, again, we saw trends for decrease in both spontaneous preterm birth and iatrogenic preterm birth, with this finding of iatrogenic preterm birth less than 34 weeks also statistical significant. We then showed in this article, again, about preterm birth COVID-19 in AJOG-MFM 2020. These are term deliveries. These are preterm. Again, the 2020 COVID time was significantly less, as I told you, 25% less. And you can see trends and sometimes significance for less preterm births, including early preterm birth and very early preterm birth. We were not alone in noticing this 25 to 50% decrease. In fact, I looked at the data because there were some early reports from Europe, Denmark, and Sweden. As we were looking at our data, Israel reported their data. Others in the US have reported similar data. And as far as I know, there are about 10 reports now in the literature. And except one study, we didn't show any differences. I would say 90% of the published studies so far have shown a decrease in preterm birth, both spontaneous and iatrogenic, during the pandemic of COVID-19. Why that is, I don't know, but many have suggested reasons, and here they are. Less stress and anxiety, maybe because of working from home. The work changes of not doing shift work, maybe, not having long hours, less physical work, maybe even better support at home, also the partner and the family are around more. Maybe staying at home leads to better nutrition, more exercise, better hygiene, and obviously less physical interactions lead to maybe less infection, less chance of being able to smoke or use drugs, less stress and accidents from driving, less air pollutions. We see highways with a lot less people around. Maybe the government checks in the US made a difference. And maybe, and this is, I think, the most troubling and interesting part, is it there may be less visits, even if we did a lot of telehealth visits at Jefferson. So in terms of visit, there are a lot of visits, but the word telehealth, is that change in how we cared for people made a difference. And I think this is up for discussions, but I think that this should open the door for a lot more research, because again, at 25%, up to 50% in early preterm birth, very early preterm birth decrease, it's something that needs to be studied, especially because it was reported pretty much everywhere in the world and very, very consistently. So we need to figure out why this happened. I'm a lover of evidence-based medicines, of randomized trials and evidence. We're preparing the 4th edition to these 2 books. And I hope to be able to continue to do a lot of research, show you new data all the time. And I thank you very much for your attention. Thanks for listening. Thank you.
That was great. Like I said, unfortunately, we don't have Dr. Bergella with us. I've jotted down for myself a few questions or comments that I'll have, but again, let's hold those and let's turn the floor over to our colleague, Dr. Woodworth.
Great, thank you so much. I'm going to share my screen here. Do let me know if you can see the PowerPoint, and if it's in the appropriate.
We can.
Oh,
I can.
Sorry, are you seeing it in the slideshow mode?
Yeah, we're seeing in slideshow mode.
Ah! Oh dear. Is that better? So
That's
sorry about
perfect
that.
on my end.
Okay. Well, let's just go with that, if that's okay with everyone. Sorry about that. All right, so my name is Kate Woodworth. I'm a pediatrician by training and currently working as a medical officer at CDC. My current role is on the Pregnancy and Infant Linked Outcomes team, which is a part of the COVID-19 response here at CDC. Sorry, I've got 2 screens now and I can't quite tell what I'm sharing with you and what I'm not. A quick outline. I was going to mention a little bit about COVID-19 and pregnancy. It might be a little bit of duplication, and so I'll try to go quickly through that. Talk about what we know, including things like transmission during pregnancy, delivery, and breastfeeding, specifically the publication that we looked at, so birth and infant outcomes among pregnant women with COVID-19. And then touch a little bit of what we're doing to learn more and how we communicate our findings here at CDC. So just for briefly background, it's been pretty well established that there are physiologic changes of pregnancy which might increase risk of severe illness, including things like increased heart rate on oxygenation consumption, decreased lung capacity, shift away from cell-mediated immunity. And we know from other severe viral respiratory infections, they can be more severe in pregnant women, the most well-known being influenza. Additionally, in addition to sort of causing more severe disease in the mom, we also know that there may be an increased risk for pregnancy-related complications. And so SARS-CoV-2 infection itself is associated with a prothrombotic state. So there are definitely concerns about increased coagulopathy during pregnancy and therefore among pregnant women with SARS-CoV-2 infection. And then there have been some observational studies. I think this is sort of still to be determined, but some observational studies showing increased rates of a preeclampsia-like syndrome in women, particularly with severe COVID-19. So other sort of negative impacts on pregnancy. And then, there's been quite a bit of published literature. I think that's probably a huge understatement sort of in 2020 about SARS-CoV-2 in particular. But including on COVID-19 and pregnancy. And so just wanted to highlight Alati and colleagues from the University of Birmingham in the UK put together a living systematic review and meta-analysis seeking to identify risk factors for severe infection during pregnancy and delivery and to report on adverse outcomes. And so their review sort of described that pregnant women compared to non-pregnant women, maybe less likely, to show symptoms of fever and myalgia, but overall have an increased likelihood of admission to the ICU, need for invasive mechanical ventilation, might have higher odds of preterm birth, and then their neonates are more likely to be admitted to an ICU. And they did identify some specific risk factors for severe COVID-19 in pregnancy, which are actually pretty similar to those that we see in the general population. So older age, higher body mass index, and specific underlying conditions. So we at the CDC put out a report in October on women of reproductive age of SARS-CoV-2 infection by pregnancy status. And so that is what this is describing, to sort of look at to whether or not women who are pregnant are at higher risk of severe disease compared to women of reproductive age who are not pregnant. And so the benefit of sort of using the surveillance data, as you can see here, that we had quite large numbers of women to be able to be powered to look at this. And these are our results from that paper. Again, this is from October, but showing sort of an increased risk of ICU admission, mechanical ventilation, use of ECMO or life support, and also an increased risk of death. And so this study, along with a Alati review, is what we use to put together changes on our website, shown here to describe that pregnant women are at risk of severe illness. And this was a change from initially early in the pandemic. We had to use language like might be at risk of severe illness. And so I just wanted to point out a little bit of how we got that and how we sort of changed that language, because I think another understatement from the year of 2020 can be the importance of public health communication. And so this is sort of when we started using that simplified language of pregnant women are at increased risk of severe illness compared to non-pregnant women of reproductive age. Just briefly wanted to go into what we know about transmission of SARS-CoV-2 infection during pregnancy, delivery, and breastfeeding. So fortunately, mother-to-child vertical transmission does appear to be rare, but there have been a small number of reports documenting newborns that have tested positive immediately after delivery, despite no contact with their mother who is SARS-CoV-2 positive, raising concerns about possible transmission, either in utero or sort of during delivery. In addition, there have been a few reports about infants testing positive for IgM antibodies, which are known to not cross the placenta. So that would indicate that the infant has come in contact with the virus themselves and therefore is making an immune response. So IgM positive is sort of concerning for transmission in utero. So there have been a few cases of that reported in the literature. But overall, the extent and clinical significance of vertical transmission, I think, is unclear. But certainly postnatal transmission remains a concern for these newborns. COVID-19 and breastfeeding. So there have been some documented cases in the literature where samples of breast milk have tested positive by PCR for SARS-CoV-2, meaning that pieces of the virus have been detected in breast milk. But the overall current evidence suggests that it is not a likely route of transmission. So there have been papers describing no difference in positive testing in neonates, regardless of how the mother breastfed or whether or not the infant was rooming in with a mother. And so overall, the WHO, the CDC, AAP, everybody continues to recommend that breastfeeding is best for infants, even if moms are positive for SARS-CoV-2. However, there are precautions that we recommend for moms with active SARS-CoV-2 infection to sort of decrease the risk of spreading the virus to the infant by respiratory route. And then disease severity among infants. So SARS-CoV-2 infection among neonates, so those less than or equal to 28 days of life, does appear to be uncommon. And the majority of those infections that have been described in the literature are fortunately, often asymptomatic or have mild infection. However, we do know that neonates are getting infected. And we do think that preterm neonates are sort of at more risk of higher disease severity compared to others. And then overall in the literature, in general, we think about children, the sort of large category of children, 1 to 18 years of age, of being less risk than older adults. And one of the benefits, one of the silver linings of this pandemic. However, the limited data we do have suggests that infants less than 1 year of age may be at higher risk of developing severe illness compared to older infants. So again, something to consider when we're talking about the population of moms and babies. So what are we doing to learn more about the impact of SARS-CoV-2 on pregnant women and their infants? So this is just a slide describing what we at CDC have put together in terms of our emergency response. So there is a dedicated team within our larger incident management structure that's dedicated to pregnancy and infants, and that's the team that I sit on. with our goals being to better understand the epidemiology of COVID-19 among pregnant women and infants, coordinate the work across the response that has to do with this population, and then inform clinical guidance, like, the example I gave earlier about our web language. And we're mainly staffed by a lot of us who do this during our day jobs. So those of us who work in the Division of Reproductive Health, or me personally, my usual job outside of the pandemic is within the Division of Birth Defects and Infant Disorders. So putting together experts that already exist at CDC to focus on COVID-19. So a big piece of our main work, and where this paper that I was asked to talk about came from, is from our surveillance network that's entitled Surveillance for Emerging Threats to Mothers and Babies Network, or SETNet. It's a little bit easier for me to say, so I'll call it SETNet. And so this work really came out of the work that had been done during the Zika virus response in 2015-16. And so at that time, there was a real need for doing what we call linked longitudinal surveillance. So not just doing, infection in women separate from surveillance of babies, but really linking that to sort of understand the full impacts of exposure in pregnancy through early infancy and even early childhood. And so we learned a lot from that response in putting together the US Zika Pregnancy and Infant Registry. And early in 2019, we sort of started to pivot that work to apply it to adapted surveillance for syphilis and hepatitis C, so other re-emerging threats at that time. And then as we were standing it up for those infections, we were able to pivot to COVID-19 when the pandemic hit. So using that same approach to do surveillance for COVID-19 and pregnancy. And just a little bit more on the background, because that helps to understand the methodology for this paper. The way that SETNet is structured, we have general variables. So there are specific variables like pregnancy outcome, estimated date of delivery, preeclampsia that we want to know for every pregnancy for all of our exposures. And then that creates sort of this modular system where we can then attach on sort of COVID-19 specific variables that we want to know depending on the exposure of interest. And so we took what we had previously put together for syphilis and hepatitis C to apply it to develop a COVID-19 module. The way that the surveillance works is we have 4 data sets. So we have a set of variables or data elements that we collect on moms, a set of data elements that we collect at sort of the birth time point, and then we include an infant follow-up piece, so after delivery, and then we collect labs for moms and babies. This information comes from our state health department partners, which I'll talk about on the next slide. But we pull from existing data sources. So we use vital records, birth hospitalization medical records, prenatal care visit medical records, and then the National Notifiable Disease Surveillance System case report. So in this, for COVID-19, this would be our general case surveillance COVID-19 case reports. For birth, a lot of these are coming from the same existing data sources, and then infant follow-up, we pull mainly from medical records, but we also link with vital records, hearing things like early hearing detection and intervention, newborn screening results, pulling from existing data sources to sort of complete our data elements. And then this is a slide showing the jurisdictions. So we work with our state and local health department partners to gather this information and do this surveillance. And so these are the jurisdictions that have been reporting to us through SETNet as of January. And we have a couple additions even now in February. So this continues to expand. But we do work with, the state and local health department partners in Nebraska and Kansas have been supporting our surveillance efforts. And we have excellent partners, and again, they're all pulling from their past experiences with Zika, and some of them for hepatitis C and syphilis to do this work. So that was a lot of background, but wanted to really share how we do this surveillance because I think it's important. And so the paper that we put out end of October, early November, was describing using that SETNet data surveillance that we have to describe birth and infant outcomes among pregnant women with lab-confirmed SARS-CoV-2 infection. And so again, we're really focusing on the women that have sort of confirmed infection at any point in pregnancy up to the day of delivery. So at that time, we had included 4,442 women with SARS-CoV-2 infection and known pregnancy outcomes. 9% of them were asymptomatic, about half of them were symptomatic. And again, because this is public health surveillance, and this is why I wanted to sort of describe the methodology, we do have a fair amount of missing data. And so some of it is a little bit messy. So we had 39% were missing symptom status. But of the nearly 4,000 live births that we had reported gestational age on them, 12.9% were preterm, so less than 37 weeks. And I put the breakdown there on the slide, sort of, you know, and these are a similar breakdown to what we see in the general population of preterm births, but most of these are going to be late preterm births, but that's the breakdown there. And then this next slide is sort of showing, I have an animation here, but maybe I don't. There we go. The next slide here is showing differences in the infant testing. So one of the things that we wanted to look at was whether or not these infants are testing positive about concerns of perinatal infection. And so a couple of things to point out here. So we had 610 infants that had reported SARS-CoV test results in our surveillance system. Fortunately, again, perinatal infection appeared to be frequent. Overall, it was 2.6%. And primarily occurred among mothers that had symptomatic infection. But something important to note is that, you know, we still saw infants testing positive that were born to asymptomatic mothers. So it wasn't just symptomatic or really severe infections that were, you know, being transmitted to the infants. It was all women. And then the other important thing is, you know, we were primarily seeing this among moms who had infection really close to the time of delivery. So most of these moms were identified around the time of delivery. We did have one infant that was born to a mother who had infection identified 12 days before delivery, but she was still PCR positive at the time of delivery. So we're not really seeing this in moms that have recovered from prior history of COVID-19, which is important and reassuring. And then this is just sort of another slide breaking down differences in testing and percent positivity by premature and term infants. And so we did see a higher rate of positivity among infants who are preterm compared to term infants. And then also just showing that among those who were admitted to the ICU and who were term infants, we did have one infant testing positive. And so that was our publication that we have put out. But just wanted to sort of share some updated numbers with you all through January about that same surveillance system that we used to report on. That was from October, but now we've had sort of more reporting, unfortunately, continue to see positive cases, including among pregnant women. So we're actually up to over 10,000 pregnant women enrolled in this surveillance right now, but this is the breakdown. We're still seeing primarily women with infection in the third trimester, but do expect to continue to see this first trimester number increase. So we'll continue to report not just on outcomes among women who have infection at the time of delivery, but we're also interested in the outcomes among women that have infection earlier in pregnancy. We continue to see an elevated percentage of preterm birth compared to the general population. So I should have said this earlier, sorry. But in general, in the US, we see about 10% of births are preterm. And so that was the number that we were relatively sort of pulling together to sort of answer whether or not this was elevated. And I'll talk about that in a minute too, because that was not a statistical comparison, and that's important. And then this is the updated number. We're now up to 1,000 infants with laboratory testing. We have 42 who have tested positive by PCR results. And we continue to see that this is primarily among women with infection identified at the time of delivery. So in summary, from the data that we're using from the surveillance system, but also some of the literature, we continue to say that pregnant women are at increased risk of severe illness from COVID-19 compared to non-pregnant women. And that pregnant women with COVID-19 might also be at increased risk for other adverse outcomes, including preterm birth and stillbirth. And you'll notice that we, the language that we use, which I pointed out earlier is important here, we still say might also be at increased risk of preterm birth, because I think there's still a lot of work to be done in this space. Preterm birth and the factors that contribute to it are complicated and multifactorial. And so we're working on an analysis right now to better describe preterm birth within our surveillance system. And some important things to look at are other risk factors for preterm birth, And so some underlying conditions in particular, we also need to describe preterm birth by specific race ethnicity, because in the general surveillance or the general US population, there are differences in frequency of birth by race and ethnicity. So another thing that we plan to control for in our future analyses. And then thirdly, I think is important is to be able to describe, which women with SARS-CoV-2 are at highest risk of preterm birth. And this is where the previous presenter had talked about also, is it with women with the most severe critical COVID-19 illness, or is it also occurring in women with more mild infection? There's been a lot of literature out recently about the impact of SARS-CoV-2 on the placenta. And so might there be some, pathologic changes occurring in the placenta, even if we aren't seeing sort of the severe respiratory manifestations in pregnant women. So I think there's still a lot of questions about preterm birth, and I'll talk a little bit in a second. Promise I'll let us have some discussion, but I'll talk a little bit more about other systems that have found similar findings to ours about increased risk of preterm birth. But again, just wanted to share some of how we're communicating these findings to pregnant women, their families, healthcare providers. The CDC website shown at the bottom of this slide does have a sort of one-stop shop toolkit we're calling for pregnant people and new parents. And so this has information about COVID-19 and pregnancy, breastfeeding, newborns, vaccine considerations, what to do, some clinical care guidance for healthcare providers and healthcare settings. We also have some of this information I described today is up on our website. We do weekly reporting of the number of pregnant cases, but also monthly reporting on these birth and infant outcomes that I've described here. So just wanted to say a quick thanks to all of our participating jurisdictions. Again, this comes from health departments who are really doing the boots on the ground work that I cannot thank enough for their work on the COVID-19 response in general, but also wanted to thank our team and the CDC leadership. So that is the end of my sort of slides in this presentation. I do have a few backup slides on some of the vital statistics reporting about preterm birth as well, but I've been talking a lot, so I want to turn it back to you all and make sure we have time for discussion. So thank you.
Well, thank you. That was fabulous, and I'm thrilled to all the pieces that you said throughout your presentation. I have been fascinated personally by the SetNet data set, and so I was particularly pleased to see you walk through for us a very diverse audience we have here. The methodology associated with that. And I would like to point out, I saw on our list here that the Title V director for Kansas, one of your states, has joined us here today too. So she probably had some role in helping to get this data in Kansas. So I have a question that jumps out to me, and that is the number 13. It is such a small number. So how do you get to the point from having only 13 to making policy recommendations? Would you mind just talking through that for us a little bit?
Do you mean the 13, the percent, sorry?
The number that there were, on your first slide, it showed that there were just 13 people women who had tested positive for COVID, and back, no, it's after, it was like table 1, I think. It was like one of your tables, maybe the first table. Yeah, isn't that 13? Isn't that under the people who tested positive results, there was an N of 13? Or 16?
16, yeah, so 16 is the number. Yeah, so 16 is the number of positive neonates that we had at that time. So this is infants who are testing positive during birth hospitalization. And so these are infants born to women with SARS-CoV-2 infection. And so yes, it is a small number, and one that we're sort of still collecting information on. Like I mentioned, we're now only up to 42. And so this is trying to look at sort of that the transmission from moms to neonates, again, around the peripartum time. We don't have enough information to describe if this is in utero infection versus postnatal, because we don't collect information about, routinely it's not being done, testing about amniotic fluid or placental tissue. And so I think that's a great point. And I think it really stresses the importance of doing some more national and more widespread surveillance. I think this is something that we would not be able to necessarily pick up without that, because it is a rare outcome. 2.6% is pretty small. But also, I think it's important even to share that that number is small, right? And so this is, a number that we've tried to say should be reassuring for moms, that even if they are, infected around the time of delivery, the risk of transmission to the neonate is low. And then that's something that we're also seeing, I think, in some other published papers now out of other countries too. So Spain just published some of their perinatal registry and saw similar numbers. I think they saw about 3%. And so again, sort of trying to communicate that that is a small number, and then that's something that is reassuring. But we do use that number to say that, our current recommendation is that all newborns born to moms with SARS-CoV-2 infection in pregnancy or at the time of delivery, so active COVID-19, all of their neonates should be tested. So even though it's that 2.6%, it's relatively small, it's based off of a small number, we are using that to sort of justify some of our messaging. That messaging be that these neonates should be tested because it does impact the infection prevention and control measures that would be taken in the hospital. So prevent transmission from that potential neonate to healthcare providers, to other caregivers. Important to think about, oftentimes these caregivers are grandparents or people with higher risk conditions that might put them at risk. And then also important for, which, again, I'm a pediatrician, and so I do see patients in practice half day a week. We've seen a lot of neonates, and it's important for us in our practice to be able to know the test status of that infant and know what appropriate infection prevention precautions to take in the outpatient setting on follow-up. So the overall message is, it is rare, which is reassuring for the neonates, but still important to know which are positive, again, for infection prevention control measures.
I think there's a little bit in that response for everybody here in the audience. So there's pieces about the methods that are interesting to epidemiologists like myself, and there are pieces about this that are interesting to our public health practitioners that are out there trying to figure out messaging that goes to folks. There's pieces that are interesting to our students and alumni that are here, that are thinking about the training that they receive in an MPH program and why that might be valuable in the real world. So there's just so much in there. So thank you for that.
Yeah.
Let me ask Maya Tabet or Maya Terry. I know we had talked a little bit about this presentation beforehand. Do either of you have any questions for our panelists?
First, thank you so much. Sorry, Maya, do you want to go ahead?
No, I was just going to read one in the chat, so you can go ahead.
Okay. So first, thank you for the presentation. I guess my question has to do with the population characteristics. And you had mentioned that that we know from the literature that COVID-19 is more common among Black race. So I was wondering if you looked at the population characteristics of these women and how much those characteristics might have contributed to the higher risk of, or to the higher rate of COVID, of preterm birth.
Yeah, that's a great point. And again, when we sort of described the preterm birth rate that we were seeing, so I'm realizing I'm scrolling up and down here. But when we looked at sort of preterm birth among our population, in our initial analysis, we didn't really account for race and ethnicity. So we didn't try to control for those factors. It was sort of a brief description of the information that we had, but that's a really important point, right? And so something that we are looking into now, we're just trying to dive into some of our, to do a more detailed analysis of preterm birth. So one interesting thing that we saw in our data, and I'll pull it up while we're talking, but we saw a higher percentage of women who were actually of Hispanic or Latina ethnicity compared to both the 2019 birth population, so a higher percentage than were giving birth in 2019, and also our case surveillance data, so the general population of people with COVID-19. And so I think that's something that we need to explore a little bit further, is why we're seeing nearly half of the women within our surveillance are Hispanic ethnicity. And so something that we're going to look into more. But we're also seeing, again, similar to the general sort of case surveillance data, a higher percentage of women who are African American, and they have some of the higher rates of preterm births. And so something that we need to look into further. The National Center for Health Statistics is looking at this with some of their birth certificate data. And they haven't done statistical comparisons, but they do have up on their website frequency of preterm birth for the 2020 year by race ethnicity among women with COVID-19. And they are also seeing higher rates of preterm birth among each sort of racial and ethnic group. And so I do think it's something that we're going to see across the board. But again, sort of it's that compounding effects, right, of some of this, societal, systematic level racism impact of our health disparities among women of color, compounded with some, other impacts of, the sort of disparities in, negative birth outcomes, but also COVID-19. So it's a really complicated area to tease out. But I think, the messaging is a little bit probably going to be the same, and that unfortunately women of color are at higher risk of some of these adverse outcomes for birth in general, but also for COVID-19. So it's an area I think needs a lot more work. So it's sort of the unsatisfying answer.
No, thank you so much. Yeah.
Maya, Terry, would you mind walking us through some of the questions in the chat?
Yes. So the first one was, will the SetNet database be publicly available?
So we are publishing on the web some of our raw numbers, some of the numbers that are reported to the surveillance, and I can provide that website for you all. The information that we get is actually protected by something called an assurance of confidentiality, which makes it a little bit more challenging for us to provide public data sets. It is something that we eventually intend to do. But it means that our data are much more protected even than sort of the general HIPAA or privacy laws. So it's an extra level of protection, which is something that we tend to ask for anytime we're asking for sensitive information. So things like pregnancy loss. And so right now, again, there is, we're trying to make this data as public as we can. So trying to publish some of our reports and outcomes in a timely fashion, but the general data set is probably not going to be publicly available for a while at least.
So the next question is that they see that there's a toolkit for pregnant people. Is there any surveillance data for transgestational parents as well as cisgender pregnant women?
Yeah, that's a great question, and something that we've been struggling with a little bit. And I'd love to hear, other thoughts on this. But I will say that when we set up our Surveillance for Emerging Threats to Mothers and Babies network and put out what data elements we would ask for, we didn't ask for either sex or gender. So we're not collecting sex or gender in our surveillance. However, we put out the inclusion criteria of pregnant women. And so we did use that terminology when we put out sort of this data. And so most of what we report on now is actually coming from women who are identified as female through some surveillance. So oftentimes it comes, well, the majority of the times it comes from the case report forms or the laboratory report forms. And so that might be, self-reported sex as female, might come from a medical record. And then, so all that to say, most of the data that we have is coming from women who are identified through medical records as female. But we have been trying to be more inclusive with some of our messaging to recognize that, this is not messaging for pregnant women, this is messaging for pregnant people. And so you'll see on a lot of our toolkits, we try to use that terminology of pregnant people. But in our published reports, we do use terms like women and females because we're using, it often comes from data sets where we're limiting to that information. So I think, how public health moves in the sort of area of collecting information on gender identity is a big unknown, and it's something that we're trying to keep up with, but it's challenging, and a lot of our data systems are old and outdated. We collect, by variable sex variables when we do, or we have systems like SetNet where we didn't even bother including whether or not the person was female, male, or their gender identity. Sorry, so this is a very long-winded answer to say that it's an area that we can do better in, but we actually don't have any information about trans or any information about gender identity in our current surveillance system. There was an MMWR published earlier this week that sort of described, outside of the pregnant population, that people of sort of other, sexual orientations or other gender identities are probably more at risk of severe COVID-19. And so we could try to extrapolate that to the pregnant population, but I think that gets problematic. So another long-winded answer to say we don't have that information right now.
Lindsay Hansen had 2 questions. She was wondering if you're collecting data on whether these preterm births are a result of spontaneous preterm labor or from induction of labor. And then also about the preeclampsia-like syndrome. Are you seeing the syndrome affecting the severity of symptoms and features of pre-E? She is a labor and delivery nurse who took care of a young COVID positive patient with no significant medical history this week, who is 24 weeks presenting with preeclampsia with severe features, who went on to develop HELLP syndrome just during the duration of her shift, and was curious to how COVID might have affected the severity of her case.
That's those are some great questions. So in terms of whether or not preterm births are spontaneous or medically necessary or medically induced is important. We do collect information about whether the delivery was induced or not, and that's something that we intend to continue to describe. But teasing out can be complicated. But again, something we do hope to describe. Another thing that we were interested in, I think, earlier in the pandemic, and has fortunately not been as much of a concern, is sort of the C-section rates. So a lot of the early data out of China were showing some really high rates of C-section among these women, and elective C-sections or sort of medically indicated, but for COVID-19 C-sections. And so trying to describe C-sections, emergency C-sections, and then induced deliveries is something that we do intend to do some more of. So stay tuned for that. And then this question of COVID-19 and impacting, preeclampsia is a real chicken and the egg one for us, I think. And so, some of our data that we're looking at now is, does preeclampsia make you more likely to have severe COVID-19? And then does COVID-19 make you more likely to get preeclampsia? And so that second question is one that our current surveillance is not really going to be able to answer, because you need to have that comparison group of women with infection and women without. So our comparison group within SetNet, all the women that are enrolled do have SARS-CoV-2 infection, and so that's going to come from some of our really important academic partners. And so I'm here representing the federal government, the public health, the surveillance side, but this is sort of an example of where it's really important to have these sort of academic studies as well, because you need to have that that cohort design or case control design where you have sort of the negative women to compare it to. So take a group of women with COVID-19, without COVID-19, and compare rates of preeclampsia. And so we will be able to describe sort of overall frequency of preeclampsia among women with SARS-CoV-2, but it's really important to have that more in-depth study. A lot of the surveillance efforts, at least I see our role as sort of describing the information that we have, but also being hypothesis generating. And so, develop some questions of things like, hey, this is a higher frequency of preterm birth than we would have expected. Why is that? And then sort of generate the next step, which is, delving in with some additional studies to support that, looking at different populations, different study designs to sort of answer those questions.
I see one more asking about if location of birth was a considered variable, such as zip code, if it was on at-home birth.
Mhm. Yeah, unfortunately, we don't collect information on whether or not it was a home birth or in hospital. And so we won't be able to describe that, which is unfortunate. We do collect zip code level data, and a lot of our jurisdictional partners are providing some information on a county level, I think mostly. So Tennessee, for example, just off the top of my head, has put up on their public reporting website some information about pregnant COVID-19, women with COVID-19 and pregnancy by jurisdiction. So to see highest impacted counties, which is really important, especially as we're getting into, a phase in the epidemic where we're seeing a lot of sort of hot spots, I think is the buzzword. So, specific areas of the country which have a lot more transmission at a given point in time compared to others. But is also important for when you're thinking about resource allocation, about vaccination efforts, but also, things like, is this happening in a rural community where they may not have access to all levels of care that some of the other settings do have. So I think it's really important for our jurisdiction partners, if any of them want to speak up about knowing this sort of level of detail for their jurisdiction, sort of county level information.
Well, as you all can see, it has been a little more challenging for Dr. Woodworth because her panelists turned into a panel of one, and she has been fielding all of our questions, but we're the lucky ones because we are just so thankful for your time, and all of this information is incredibly helpful to each and every one of us here for different reasons. So on behalf of myself, the Center of Excellence, and all of our guests here, I'd like to thank you so much for your time today and sharing your thoughts and wisdom and your research. Clearly, we've been inspired. We're getting close to the end of our time here, so we're going to bring this to a close because we want to keep it at an hour. However, if anybody has any questions that they would like us to share with Dr. Bergella or other questions that you might have, please be sure to put them in the chat box because we are recording this and we're going to go back and take those questions, and then we'll follow up with our panelists to see if there's any additional thoughts. So meanwhile, we will post a copy of our presentation on our Center of Excellence webpage at the SLU website. I see many old friends here for graduate